Everybody to another edition of SMISS-AP Continuing Medical Education webinar. So today we have a host of speakers from all across the world. We have Dr. Raymond Yip from Hong Kong, Dr. Luke, very well-known endoscopist from Korea, Dr. Malcolm Pestonji, a well-known figure in the spinal endoscopy from India, Dr. Hussam Jabri from Saudi Arabia. So the topic is multi-level stenosis. It's a very interesting topic. While we are used to dealing with one or two level spinal stenosis in our common practice, multi-level stenosis is a challenging area. It's a little bit of a mystery. It could be associated with or without instability and deformity. Apart from decision making, management, unfortunately, is associated with some degree of complications. A lot of patients submit dissatisfaction with when dealing with when dealt with surgeries for this kind of a situation. And again, like many other conditions in spine, this particular condition has a myriad of options available in terms of management. So each of my guests today have a different way of, belling this particular cat. To start with, the most controversial part is doing a disc replacement for this kind of a situation. So I invite Raymond Yip to start with this controversy. Welcome, Raymond.
Hi, Arvind. So I thank the SMISS faculty and OrthoTV for putting this together, and OrthoTV have done an excellent job in organizing these webinars, and thank you, Arvind. So I'll share my screen. So I think that's okay. I'll just go into presentation mode. There we go. So can everyone see my screen?
Yes, yeah.
Okay, so okay. Okay, these are my disclosures, so nothing relevant to the talk. So we know that spinal stenosis is caused mainly by disc degeneration followed by facet joint hypertrophy. So the origin of the problem is actually disc degeneration. So what happens is altered intradiscal pressures leads to loading of the posterior elements of the spine, notably the facet joints, and they hypertrophy, and the ligamentum flavum tends to infold and buckle. And together with the facet joint capsule, this results in spinal stenosis as we know it. So this is a slide showing the degrees of disc degeneration correlating to the amount of facet joint degeneration. So you can appreciate going from top to bottom that the disc, as the disc degenerates, the spinal canal becomes narrower because what's happening is the disc is bulging out and the facet joint is bulging inwards. So long-term consequences, this changes the entire spinal biomechanics. So we end up leaning forwards, and as one disc degenerates, it becomes stiff. It initially becomes unstable, but as it becomes further and further collapsed, it leads to changes in the adjacent levels. So we have progression of disease, progression of spinal stenosis. And this is what we're saying. So normal disc, everything is fine, but if you have a degenerated disc, load goes onto the posterior elements and they degenerate as well. So we don't see facet joint degeneration with a normal disc. So in the past, we've been performing spinal fusions to treat this with the concept of indirect decompression, and an A-lift or an X-lift or an O-lift is far better in this regard than a posterior surgery because we're maintaining the disc height. So a large footprint cage to maintain the disc height. However, when we're performing spinal fusions, you can have problems. So this is a spinal fusion, and you can appreciate that all that's been done has been, all the decompression has been achieved by ligamentotaxis. So by restoration of the disc height, the spinal stenosis disappears and the spondylolisthesis often reduces. So MRI before and after, this is after spinal fusion. So, however, there are consequences of spinal fusion. So this is a patient who had a spinal fusion at 4-5. 3 years later, the 3-4 disc degenerated. The surgeon opted to treat this by fusing another 2 levels. However, within 3 months, because she's osteoporotic, there's a stress fracture or vertebral compression fracture at L2, and the surgeon elected to treat this by doing another spinal fusion above. But you can see what happened. The screws pulled out. Patient went home, bent forward, screw pulled out, and had the whole spine fused within 6 months. So we are creating a fixed deformity. So when we perform spinal fusion, we can only accommodate the standing posture. We can't accommodate the sitting posture. This is an example of one of my patients. I've done a spinal fusion in 2014, and by 2017, adjacent segment disease is very apparent. So we're creating a problem. Another patient with a 2-level spinal fusion developed distal adjacent segment disease. So it's not benign. We know that if we perform a spinal fusion, the loading to the sacroiliac joint distally increases, and proximally, there's also increased loading. So how about performing the same surgery, but instead of using a very big cage, we put in a disc replacement instead, and this preserves the spinal motion. So we're probably not seeing adjacent segment disease now. So instead of putting an XLIF or an ALIF cage in, we are putting a TDR in. Example 1. So this patient has back pain for over 10 years, and she's got recent onset severe back and left leg weakness, cannot walk, PIL mismatch. So there's a 27-degree mismatch between the PILL. She's got a degenerative scoliosis developing. She's gone into kyphosis. You can see multiple levels of disc collapse. And what's happened on the MRI is that the 4-5 and 5-1 discs have collapsed. They're not moving very well, and it's resulted in a massive disc herniation at 3-4, which you see here. So it's a sequestrated disc herniation at 3-4 on top of her problems at 4-5 and 5-1. And these are the spinal stenosis at L4-5, spinal stenosis at L5-S1. The vacuum discs, so the discs are gone. The discs have dead. So sequestrated disc collapse, asymmetric collapse, and the 2-3 disc is also bulging. So if we do a spinal fusion, we should probably fuse the whole lot probably from T10 to pelvis. Can we do a lesser surgery? So she had a 3-level TDR. So all the spinal pelvic parameters came back to normal. Her back pain is just 1 now, and leg pain is all gone, 3-month follow-up. And we've got a comparison MRI before and after, and you can appreciate this is just achieved by indirect decompression alone. There's no need to touch the posterior elements. Example 2, another patient with back pain for 10 years, sudden onset right thigh pain and knee weakness. Again, a disc herniation, sequestrated disc herniation at 3-4, causing the new problem. So again, the collapse of 4-5 and 5-1, putting adjacent pressure on the 3-4. The 3-4 disc is degenerated, it's herniated, and he's got a new problem with thigh weakness now. And that's the hernia at 3-4. So there's 3-level pathology here. Some stenosis at 4-5 and 5-1. So total collapse. And you can see why the pressure's on the 3-4, because there's not much movement here at the 4-5 and 5-1. So we've done a 3-level TDR, and this is him 1 year after. He's gone skiing. He's just said, thank you for the new back. Another patient with degenerative kyphoscoliosis. She already had, notice she already had 2 cervical TDRs. So she came to me with this big deformity in the lumbar spine and progressive back pain and leg pain, buttock and leg pain, with radicular and mechanical back pain symptoms. So she really had no pain after a cervical TDR and asked me, could I do a TDR for her for this deformity? We measured the segmental lordosis, the segmental curve over the major deformity, and it was 30 degrees. So do we do a big surgery like a T10 to pelvis for her, anterior spinal fusion, or can we do a lesser surgery? She's got vacuum discs at 3 levels, 3, 2, 3, 3, 4, 4, 5 vacuum discs. The 5-1 facet joint has a vacuum, but the disc is intact. So there's a L5-S1 facet joint vacuum on the right side as well, because probably it's starting to degenerate, the 5-1 as well. So she had a 3-level TDR. This was done in 3 hours, just over 3 hours, the whole surgery. And this is the result. So she went back to full-time work in 6 weeks, stopped all pain medicine, and just a little bit of back pain, but no leg pain. All the radicular symptoms disappeared. And this is the comparison X-ray of before and after. So you can see a massive improvement and the virtual complete correction of the segmental curve and some tilt at the L5S1. We repeated the CT just to see what we're dealing with, and we saw resolution of the facet joint vacuum at L5S1. So even the adjacent levels are getting better from this surgery. So if you look before, there's a facet joint vacuum here, it's disappeared with the TDR. So the L5S1 is actually doing better after the surgery than before, and the tilt over the L5S1 is decreased. And you can appreciate the vacuum at the L5S1 has disappeared as well after this. All implants have bonded. She's been pain-free. She's 2 years follow-up now. Another patient, 59 years old with back and leg pain. There are 2 collapsed discs, mainly at 3, 4, and 4, 5. The MRI showing spinal stenosis at 3, 4, 4, 5. We did a 2-level TDR. This is the result of this is the MRI after the surgery, just a comparison before and after. So in conclusion, indirect decompression from restoration of disc height from TDIs are viable options for patients with multi-level spine disease, secondary to disc and then follow-on facet joint disease. And we're directly addressing the origin of the problem, which is disc degeneration. There is no need to violate any posterior structures, and this is minimally invasive surgery because the patients go home the next day. Compared to spinal fusion, motion is preserved, and thereby reducing the risk of any adjacent segment disease. And we can also do a smaller surgery than had these been fusion surgeries. Thank you.
Thank you so much, Raymond. You really made me get off my chair with this very unconventional approach. I'm sure most of the audience will have a lot of questions for you. Be ready for your questions. That will be at the end of the entire session. So I would now request our own Dr. Jin Sung Kim Luke. He is very popular all across the world for his contributions to MIS, and we are fortunate to have him today on our broadcast. Dr. Luke, please go ahead.
Yeah, thank you. So can you see my screen?
Yes.
Yes.
Yeah. So very happy to see you, right? We used to have the webinar a lot during the pandemic seasons, but
Yes.
recent days, face to face, yeah, is much better, but it is still good educational tool for circulate the knowledge and expertise with the very convenient manner. Yeah. So this is I actually prepared these 3 cases, having the different sort of the spinal stenosis. This is my learning objective for today. So select the appropriate MIS endoscopic procedures, recognize the changes of spinal alignment following the decompression alone, and figure out the pros and cons of the endoscopic, what I mean, the unipolar, bipolar, and sort of the pyramidal procedures. Yep. Starting with the fusion, and we also have the different sort of the microscope, unipolar fluendoscope, and bipolar decompression. There are obvious different pros and cons among the different skill set. Let's see the first case. 49 female having the 3 sons. She complained at the moment she complained of lap dominant radiating pain, but she used to have the sort of the right leg pain before. You can find the OSS3, EQ5D, and the pain score. Look at the back pain score 6. Yeah, leg pain, right? Leg pain. So it's the 9, right? OSS3 54 is very, very difficult, challenging, yeah, daily activity having the 3 sons. You can see, right? These are spondy at the 2-3 level, 3-4 level, rows of the distal height and 4, 5, and 5 SN. This is key image. So every single level. At the 3-4 level, the patient have the central stenosis, 4-5, ratellises. You can find the bony, the bone foraminal calcify the bony stenosis, pinching the L4, exceeding nerve root, the right side. That's why she suffered from the right leg pain too. And you can also the ratellises by vessel stenosis. I think the Raymond recommends 3-level TDL because the patient is just the middle-aged lady, right?
Yes, possibly.
Yeah. I think once I see your cases, I'm a little bit gravitate toward your surgical procedures.
It's tempting.
So tempting. Yeah, you can see the parameter, right? Rows of rhodosis and a little bit sort of the scoliotic change. Yeah, this is a problem. She has stenosis, recesses, foraminal stenosis, ratellises, 4-5 and actually because of long-lasting stenosis, ligament flavum was a little bit calcified too. So when I find the best way for the patient, so I try to find the real problem, what I mean, the pain generator and the causes of the weakness and the sort of things. And we can compare the pros and cons between the decompression and versus instrumentation. If you once you decide to go further with the fusion or with the decompression, what's gonna be best way among the different sort of the instrumentation, different sort of the decompression, right? So let's see. The most important, one of the important things I actually decided go forward with decompression, but we have the sort of the important issues, especially look at the 3-4 level. Facet trapezium is much more vertical. This patient already have low responding. So if you fail to preserve the facet joint at the level 3-4, you definitely your surgical goal cannot be met because after the compression, patient might have the progression of the responding, right? So key is how can he preserve the facet joint with the endoscope? Mm, Regarding the 4-5, not only central decompression, but also additional foraminotomy would be great because patient have, sort of the calcified bony stenosis at the level 4-5. I'm gonna show the result. So 3-4, I did the full endoscopic over the top decompression. You can see the post of MRI. The 4-5, I I did the bipolar endoscopic ULBD and interlaminar contractile foraminotomy. So through the same incisions, once I finished the over the top, my scope, my instrumentation was able to reach out the contractile foramen, right? And taking out the bony spur was possible. 5SN was simple, just ratellises decompression. I did it with the microscope tube surgery like this manner. Among the 3 level, 4-5, mostly a little bit interesting the other level. You can see the pre-op bony spur. By the over the top and additional interlaminar foraminotomy, I was able to take out the tip of SAP calcified, pinching the contractile exceeding outlet. So this is a surgical video. The bipolar microscope is very simple and goes straight. Let's see the final stage of the compression at especially 4-5, right? You can see this is SAP, the other side. Using the scope retractor, I was able to protect the dura. That's why by the endoscope, we can make the safer surgery than that of the microscope or open surgery. You can see the exceeding outlet there, right? The pathology problem at the level 4-5, proximal foraminal stenosis, one of the main problem, right? So this is the best way to preserve the facet joint as much as possible than others, right? Yeah. But this is common procedures, right? Okay. So I have followed this patient with the 3 months. So you can see the pain score, NRS 0, VAS, back pain score dropped down from the 6 to 3. There's a little bit right leg dysphagia. It's kind of the result of manipulating the DRZ a little bit, but it's patient much better. Also stress-free just over 20. She is able to have been able to return to most of the daily activity very well. Ambulation was possible without any the limitation up to 1 hour pre-op. Claudication was just 5 minutes. Swimming was possible, right? You can see the clinical outcome changes over time, 3 months. I know the similar cases of with this 1 year, 2 year, and 3 year follow-ups. You can see the changes improve a little bit, not so dramatically. Likewise instrumentation, likewise the artificial disc replacement. Okay. I'm gonna show the other cases briefly, right? This is very simple and two-level stenosis, 3, 4, and 4, 5. And this is simple cases. Just do the two-level full endoscopic decompression. This is 3, 4. This is 4, 5. By the endoscope, we can do the very safe manner decompression with the changing the scope from the big and to small one. You can compare the canal decompression was perfect with the minimal any kind of the muscle damage over the trajectory, right? You can see the facet joint preservation with 3, 4, and 4, 5. Well, the back muscle and skin incision is totally size of the wounded drain, less than 1 centimeter respectively. So let's see the other case, a little complicated. You can see the back pain was also the 9, especially 70. Patient has a lot of the medical comorbidity. You can see the the problem, the disc herniation, also facet hypertrophy, right? This is 3, 4, and 4, 5. Patient has a little bit recesses, bipolar. Using the 3 skin incisions, I was able to manage the two level decompression. I don't have to show all the video, right? Just see the end of the stage. The canal decompression was super low. So mostly the kind of the envelope removal level. Yeah, you can see the 3 skin separate incisions. 2 level, the 1 level for 2 through the incisions, the 4-5 through the 2 incisions. I followed this patient more than 1 year. You can see the outcome, super, 1 year follow, the post-immediate 1 year. So it totally will remodel spinal canal, minimal damage of the muscle as well. So this is take-home message. Conventional laminectomy? No, it's not. Yeah, available. Please keep out this in your practice. Endoscopic, full endoscopic, biportal. It is very nice to endoscopic tool to provide adequate circumferential compression of spinal canal. Yeah, preserve the stability is super with the endoscope. In case of multi-level, so adopt the hybrid endoscope, uniportal and the microscope tube and the biportal, right? So can the endoscope work well in multi-level senses? Yes, I believe it. Yeah, trust me. Thank you very much.
Hey, thank you, Luke. I'm moderating because Arvind, I think he has something on, so I'm moderating. So we'll leave the thank you for the excellent talk. And if everyone stays online, we'll have the next couple of talks, and then we'll ask questions. Is that okay? I'm sure we're presenting all of the methods to treat spinal stenosis, and then we'll just have a big discussion at the end. So next up will be, I believe it's Hussam will be next. So Hussam, please can we have your presentation?
Yes, sure. Thank you, Prof. Raymond. Thank you for the invitation. I am happy to be part of this and privileged as well. I am Hussam Jabri. I practice in Saudi Arabia, in the capital Riyadh. I am a neurosurgeon specialized in spine, in minimal invasive and endoscopic spine surgery. I will talk about multiple level spinal stenosis addressed by tubular decompression. So as tubular decompression is the optimal solution for multiple spinal stenosis, so head-to-head endoscopic decompression versus tubular decompression. My talk will have detailed comparison of surgical technique in terms of cost effectiveness, surgical duration, surgical outcome, radiation exposure, and learning curve. In terms of cost effectiveness, tubular decompression requires a fewer and less expensive study, while multiple instruments required by endoscopy. A study of Wang et al. Demonstrated that the average cost in endoscopy is in MIS tubular decompression 15% lower than that of biportal decompression. Another systematic analysis showed that the cost of tubular decompression averaged $8,000 compared to $10,500 of biportal procedure. Recent study compared the hospital cost differences between and open endoscopic spine decompression surgery. As we see in the graph, that the endoscopy has higher cost compared to open tubular surgery. What about surgical duration? Research consistently showed that the tubular decompression reduces the average operative time compared to mono and biportal surgery. Analysis by Park et al. Comparing these two techniques showed that the duration is 90 minutes in tubular decompression and average versus 120 minutes for biportal endoscopic decompression. Attributing this maybe to more streamlined approach of tubular system. The shorter operative time is associated with less anesthesia exposure, and this lowered the risk of postoperative complication related to anesthesia, as seen in the study of Lee et al. The setup for tubular decompression is less due to fewer required instruments and less complex positioning, less need of X-ray during the procedure. It has also enhanced visualization, which provide aids in quicker identification of the area of decompression. This efficacy is particularly crucial in multiple level spinal stenosis, where time become more important, and this was seen also by study of Park et al. The ability to conduct tubular decompression is in outpatient also allows for quicker discharge. And studies indicate that 70% of patients can be discharged on the same day of surgery. In a landmark study done by Vet et al. And Prof. Luke, this randomized controlled trial compared full endoscopic tubular decompression versus endoscopic decompression. And the study suggests that the full endoscopy decompression is alternative only to lumbar spine stenosis decompression. It provides non-inferior clinical efficacy and safety compared to tubular microscopic surgery, in addition of its minimal invasiveness. And as we see from this study, ODI results, if we look at the p-value comparing these two techniques, it is not significant on long-term at the 24-year follow-up. This indicating that tubular and endoscopic spine surgery has similar outcome on the long term. And there were in this study no significant difference observed in terms of improvement of VAS score and leg score, EQ5D score, and walking time at any time point of the follow-up. In the diagrams, as we see, there is depiction of the VAS score in the back and leg, and they did not reach the minimum clinical importance of 3 points of the study at any time. But the only thing was superior endoscopic spine surgery. As we see, the full endoscopic spine surgery has more patient satisfaction, as this was measured by McNabb criteria between these two groups at 24-month follow-up. Another study from Korea, from St. Peter's Hospital, published in 2019, comparing all techniques of decompression, microscopic, tubular, and endoscopic. As we see in the patient demographics, as we see in the p-value, NS stands for nothing significant. All the patient demographics were the same. What about the postoperative pain? Postoperative pain was only significant between MIS group and open group. So there is no difference in the VAS score between tubular decompression and endoscopic decompression. And at the follow-up, the modified McNabb has improvement of more than 90% in all patient group, and success rate was comparable to all group and was not significant between MIS and endoscopy. Another study, which is strong randomized prospective study, comparing bilateral spine decompression of spinal stenosis with full endoscopic interlaminar approach. And they commented on radiological outcome that there was no increased instability in the functional examination, and there were no significant difference between kyphosis, height, and intervertebral space, and radiological instability with also clinical outcomes. An imaging study in post-operative surgery revealed that tubular decompression not only reveals symptoms but also preserve spine alignment. And a study of Wang et al. In 2002 demonstrated that 90% of patients maintain alignment at 2-year follow-up after spine decompression. Another study looked at outcome published in Neurospine, and it is a meta-analysis and statistical power analysis of 6 randomized controlled trials comparing the safety and efficacy of full endoscopy versus microscopic decompression. And the study suggests, despite that full endoscopy demonstrated more effective results in terms of leg pain relief and shorter operative time with lower complication, they have insufficient statistically power data to comment that endoscopy is superior to tubular decompression and back pain or estimated blood loss or length of hospital stays, and they advocate that they need more study to confirm this. Add to all that, how much radiation exposure is needed for us to decompress multiple level spine stenosis, especially if the patient is having a spondylolisthesis or deformity. The exposure was not measured in a lot of study, but this study showed that there is higher exposure in endoscopy, but was not statistically significant. What are the predictors of surgical outcome? There are not too much study published on patient selection for multiple level spine stenosis to choose between endoscopy decompression or tubular decompression. But this study from Germany in 2021 looked at the anticoagulation therapy and ischemic cardiovascular event, age, lumbar lordosis, and intradiscal vacuum phenomena. Interestingly, they found that patients with comorbidity of cardiac disease and intradiscal vacuum phenomena are statistically significantly associated with worse outcome. This subgroup of patients may be a good candidate of endoscopic spine surgery. Also, despite I like a lot the presentation given by Prof. Raymond, but I am not sure if these also are not contraindication for TDR. And study comparing the full endoscopy to MIST compression in the setting of degenerative scoliosis and spondylolisthesis, published by Prof. Hofstetter from Seattle, showed that all patient VAS, back and leg and ODI has improved, but again, there is no significant improvement difference, between the endoscopic and MIS cohort in long term, and the only improvement seen was in early cohort. Add to that the learning curve. The learning curve needed for tubular decompression is much shorter compared to that of endoscopic spine surgery. A study highlighted the experienced surgeon could achieve optimal outcome after performing 50 cases of MIS tubular decompression compared to 100 cases of biportal technique. In the percutaneous endoscopic decompression, limited surgical visibility through the endoscopic channel with the unfamiliarity of the endoscopic anatomy and the instrument handling can cause this learning curve also to be more and to increase the risk of complications, especially in the beginning of the learning curve of the surgeon. So in conclusion, a tubular decompression for multiple levels represents a highly effective and advantageous procedure, particularly when the patient is having abnormal anatomy due to radiation exposure, because the endoscopy is very radiologically demanding. We can overcome this by navigation, sure, and new trends in robotics. It has benefits in cost, surgical efficacy, and patient satisfaction and durability of outcome, as we see with all very powerful randomized controlled study that compared this both technique. So we will continue to be advocate for MIS tubular discectomy, because there is, decompression, because there is no one size fits all for patient care, and we have to tailor our surgical indication based on the patient presentation, demographics, and also our experience and availability of tools and training. So clinical outcomes are comparable to endoscopy and MIS, and proper patient selection is crucial, as mentioned. So in conclusion, if we put tubular to endoscopy head-to-head and compare the cost effectiveness, we found that the cost effectiveness in tubular is superior. The surgical duration is better in tubular, especially in the beginning of the learning curve. Patient satisfaction is better in endoscopic spine surgery. Radiation exposure also is more, by endoscopy. Durability of surgical outcome is comparable to both two, and the learning curve is more in endoscopy as well. I just want to correct this, maybe when. Thank you for your participation, and I would like to present my references and to thank you. Thank you.
Thank you, Dr. Hussam. So we'll have our last speaker, Dr. Malcolm, and then we'll open up for questions and discussion. Dr. Malcolm, please.
If Hussam could stop sharing his screen, I can start mine.
Sure, in a second.
OrthoTV might.
I stopped sharing, correct?
Yeah, thank you.
Thank you.
About to start my thing. Just give me a second. Yeah. And can you see my screen, please, guys?
Yes.
I'm a little lost. This meeting is being recorded. Okay, thank you. And let's start. I won't take much of your time, and I hope you enjoy my little talk. UB in multi-level stenosis. How do I do it? That is my tagline. Let's start with our first case, a case of multi-level stenosis and an old decompression being done at L3-4 and L4-5. Now patient comes with L1-2, L2-3, and multiple level stenosis at foraminal stenosis also at 4-5 and 5S1. Patient has severe sciatica in both limbs, right more than the left leg. Axial back pain is not significant, but the claudication distance is significant. If you see there is mild scoliosis, quite a lot of stabilization, old surgery being done at 3-4, collapse, then 4-5, now collapsing. And at 1-2 and 2-3, patient has subsequently developed stenosis. Post-operatively, you see we have done the flavectomy, central flavectomy over here, and decently opened up the cord. If you compare level by level, L1-2, L1-2 post-decompression, L2-3, L2-3 post-decompression, L4-5 pre-decompression, L4-5 post-decompression. But what is important here is that you see two white marks over here, and both these are the para-UV approaches along with the central decompression which has been done. Please, this is just a 2-day-old surgery of mine. These are all fresh surgeries which I'm showing you. Also at L5S1, you can see the stenosis, and here again, bilateral approach taken to foraminotomy and opening up of both roots. CT scan approaches that show you the L2-3 decompression here, L4-5 with bilateral, you can actually see the air that is still trapped inside the spine because it's a fresh CT scan. And at L4-5, you can see the bilateral approach with some air again still trapped there. If you see the post-operative CT scan, you can see that we have opened up the 4-5, 3-4, and 2-3, all foramens all opened up. Let us see this patient with an 86-year-old female, severe sciatica, same story, but back pain is less, claudication distance is horrible. And what you see here is a 3-4 stenosis, but in the subsequent cuts, you can see that there is foraminal stenosis and stenosis at 4-5. So what you see here is a 3-4. And then what you see below down here is the 4-5. I put the entire MRI plates for your referencing. And you can see that post-operatively, we have a wonderful decompression over here. We have even removed the central disc bulge by going underneath the cord. You can see the pre and you can see the post. You can see the CTs and you can see the MRIs. The decompression has been adequately and nicely done. What you see here in the pre-operative CT as a completely blocked zero opening foramen can be seen here as a completely expanded normal nerve root foramen and the disc still occupying a lower part of the foramen. So when we come to multi-level stenosis and the technical aspects on central canal stenosis, what is the principal offender? It's basically the flavum and an anterior contribution from a hard calcified disc. You can remove the calcified disc is what I've shown you. What is the end point of a flavectomy? Complete removal of the flavum. Should bone be sacrificed? And if so, how much? I believe UB preserves lamina by undercutting, and I will be showing you that video. So is complete laminectomy justified? When secondary listhesis is a well-documented phenomenon, no, it's not justified. When we are talking about lateral canal stenosis, it's usually associated with central and foraminal stenosis. Bulging of the disc displaces and crushes the root under the SAP. I will be showing a wonderful video of that to you. And what it needs is ipsilateral and contralateral undercutting to allow, and you need to remove the flavum in the lateral recess, completely decompress the SAP, IAP to allow for what is called as lateral expansion of the cord. You cannot retain flavum in the lateral side of the cord. So now we are going to play my first video. And you can see me burring underneath the lamina. I don't think, my dear Hussam, that you can go ahead and do this with your tubes. And you can see how wonderfully we are doing that. We have a hook going right through into the previously decompressed L1, L2 level. And we will be removing this complete flavum. Here you can see the intraoperative imaging. I'm already at the upper edge of the cranial interlaminar space. Here you see me going down into the lateral recess, clearing out the lateral recess onto the opposite side. It's an over-the-top decompression. And you can see how nicely laterally the cord is bulging out. Flavum is completely decompressed. The floor of the foramen on the opposite side is visualized. Central decompression is adequately done. We will skip to the next video. When we are dealing with foraminal stenosis, how do we factor it in? Access contribution from the anterior factors and posterior factors. You must understand that the foraminal stenosis is by multiple factors. All need to be dealt with, and you need to wisely choose an approach. Now, what are the approaches available to me is ipsilateral undercutting or contralateral ICLF or a para-UB. So here you see me doing an ipsilateral surgery. You can see the root, you can see the flavum that is stuck in the axilla. This is the undersurface of the IAP, which is overgrown, thickened, and pressing on the root. What is called as king pressure on the root, which we are relieving and going towards the superior pedicle and allowing for a free access to the root. But what you see is a bulging, huge disc, preventing me from even doing a proper lateral recess stenosis. So I'm going over the top, I'm decompressing, removing that disc, cleaning it up, burring down into it, reopening the foramen a little bit more. And finally, you can see the exiting root very nicely. And then when we go down onto the disc and out onto the vertebral body, outside the foramen, you can see the root is lying between two bones without the support of the disc. That, gentlemen, is decompression in an ICLF. Let us look at this foramen. And you can see that this foramen is badly trapped in the same patient. And here we are at 4-5. We are doing a para-UB approach. You can see it's a zero opening foramen, transverse process, superior pedicle, and IAP all merged, SAP all merged together. Fracturing a bit of the SAP, getting an access into the foramen, working hard, removing all the calcification within the foramen. Finally, breaking away and removing the tip of the superior articular process. But what do I see? I only see the Cambion strangle. I don't see the root yet because the root has been pushed and kinked and hooked underneath the pedicle. So I'm going parallel to the pedicle, going parallel to the transverse process, removing all those tissues from there, and finally removing the tissue from the axilla, which was hard tissue. Here you can see the bony Cambion strangle, you can see the disc, you can see the SAP osteotomy I've done, and I'm going cranial to the root. You can see the free flow of the root now, a straight root, which ensures that this patient will not have pain post-operatively. This is the third approach to the foramen when you are doing an ipsilateral undercutting. You can see the calcification flavum becoming bone over here, pulling it out bit by bit, undercutting the IAP at that depth and the SAP, fracturing out all that calcific bone over there. And at the end of my journey, you will be able to see a beautiful exiting nerve root, which you can already see now. You can see the disc below, which we further burnt and pressed inwards. And you can completely open up the foramen. Now, this, gentleman, cannot be done by many other techniques. I'm not deriding anybody, but I believe that it does hold a special advantage in dealing with multi-level canal stenosis. Though Raymond's talk today was an eye-opener, it was a fantastic talk. Dr. Kim compared all the techniques, which was amazing. It was an amazing presentation in itself. So it's been a pleasure here being with you all. Thank you, and I shall end my talk.
Thank you, Dr. Malcolm. So I believe, yeah, can we have any questions from the audience? I know there are some, I saw some names on the participant list and we have some audience members. So we'll take the questions from the audience regarding the treatment options for multi-level spinal stenosis.
Hi, Raymond. I have the question for you.
Okay.
How can you predict the restoration of the spinal alignment? I remember that case, really level arterial disc replacement in the James Coley.
She had vacuum disc there.
Vacuum disc?
Yeah, so those were the unstable levels, and the other levels were
evaluate the bending view?
Yes, we can do bending views, and but the discs above were intact. So the deformity was caused by primarily those three discs.
Mm-hmm.
I've left the L5S1.
It was so surprising realignment the spinal. Yes, realignment the spine, right?
Yeah.
So totally amazing, right? So my question, so how can you predict, right?
Well, the disc replacement is basically like a healthy disc. So all we're doing is putting a healthy disc back in to where there was no disc before. And if there's a vacuum there, there's no disc. The disc has disappeared. So by realigning that, it's like when we perform surgery for scoliosis, we only treat the structural curve, and the compensatory curve usually follows and realigns. So if I measure the tilt at L5S1, it's actually improved afterwards. It's not fully improved, but she's asymptomatic. And because we've left the L5S1, so my option was whether I wanted to treat L5S1 as well, but I've left that road open. So I could always go in on the right, on the contralateral side, and do the 5-1 TDI if necessary in the future. But the idea with doing disc replacement is we're doing less surgery and we're avoiding spinal fusion, because I think everyone here agrees that spinal fusion for spondylolisthesis, for any condition, you're creating problems for the patient further down the line. A few years later, there's a significant risk of adjacent segment disease. We're fusing the spine in the standing posture. We're not accommodating the sitting posture, and we do create problems by performing spinal fusion. So for me, it was, do I do a T10 to pelvis for all of these patients that I just presented, or do I do a lesser surgery, which is the TDR? And I don't think I could do what you guys are doing with just the endoscopic decompression for many of these. They would still have some degree of deformity and pain. I think I mean, you would alleviate the immediate symptoms, but a lot of the patients, they don't. I mean, that's the difficulty. How far do you go? So I still do a lot of decompression. So I always give them the decompression option. Yeah. The fusion option is usually not there. I just tell them, just don't go there, because if I do a fusion, I have to make sure that we look at the adjacent levels. The adjacent levels are not degenerated if we fuse it. Often we have to fuse the entire lumbar spine, because otherwise you'll come back with more problems later. So everyone here presenting the endoscopic and the minimally invasive decompression, it's excellent, because that's exactly what I would do. So the patients come to me, I give them the option for say for L4-5 spondy, just radicular symptoms, we'll decompress them. We won't do anything more. We'll just do a tubular decompression, endoscopic decompression, and that'll be it. And fusion would be, we don't do it anymore. We do TDRs, but we never go to I've got one later today at a TDR for a spondylo, because they just present with ridiculous symptoms. There's not much back pain, so just propping up the disc space would be sufficient usually.
You have another question from chat box.
Yes, let's see what we have.
Replacement through the lateral approach?
No, these disc replacements done anterior, so there's no muscle damage. Yeah. So the only thing that is risky is you have to know how to deal with these vessels. So with a posterior surgeries, there's always a risk of nerve injury. With our anterior surgeries, it's mainly a vascular risk. So you have to be vascular trained. I do my own approaches, but if you're not familiar, you have to get an access surgeon to do the approach. And the main risk is vascular, but the tissue that we're cutting, the only thing that we're cutting is the skin and the linea alba, and that's it. That's the only thing I have to repair is the linea alba. So I don't repair anything, because it's a completely muscle sparing approach. So patients often just go home the next day. The incision for a single level is 6 centimeters, single level disc replacement is 6 cm. It's an anterior wound. They don't hurt much.
That's great.
I have a question.
Yes.
Thank you for this eye-opening presentation. I would like to ask two questions. First question is, can we apply TDR through olive axis? Like we insert the olive cage, it is the same axis, but you put the TDR cage, or it should be opening through linea alba? And the second question is, what about the pseudoarthrosis? Because most of these patients are osteoporotic old. I mean, not pseudoarthrosis, subsidence, sorry.
Okay, so all TDR patients have a DEXA scan, and we now have a drug called romosozumab. And I've just had a patient today. He had a T-score equivalent to, I mean, he did get a TDR, but he wanted one, but I said no, because his T-score was not good enough. We did a T-score for him. His T-score initially was equivalent to someone 150 years old, if such a person exists. So it was minus 1.5. And we gave him 5 doses of romosozumab, and his T-score is now -1. So he's actually gained 70 years from 5 doses of romosozumab plus vitamin D plus calcium. So far, all patients have responded. So we do a DEXA scan, and if they have poor bone quality, we'll build it up. In the past, we used Forteo. Forteo, the results are not as good as romosozumab. We're getting phenomenal results with romosozumab. And we've seen 1 dose of romosozumab give the equivalent of 10 years youth back to the bone. So in all patients, they just have to wait for their TDR if they want one. So the patient today, she had 6 months of romosozumab before she could have a TDR. So the main risk with TDR is subsidence and things like osteolysis. So there are various things that can prevent it. But the TDR basically acts like a spacer, but it's mobile, so it's different from a fusion. So we don't cause the problems that when we do perform spinal fusions. And it is one of the most direct ways of addressing disc pathology, because we're actually treating the origin of the problem, which is disc degeneration itself, which is consequently causing the spinal stenosis. So it's all secondary to disc disease. So we're going right back to the origin of the problem. So for young patients, they'll get offered a TDR because that's going to sort their problem. That's going to realign their spine. It's going to prevent the adjacent level, because the disc replacement, I have seen it reverse disc disease at adjacent levels. You've seen decreasing disc bulge because we're restoring motion, taking pressure off the adjacent level.
Perfect, thank you. And regarding the access?
Yeah, so I do my own access. So if you're not familiar, so regarding the access, there are TDR devices. So Medtronic used to have something called an AMAV, which is a lumbar TDR that was put in through an oblique approach, like an OLIF. But because of financial, they withdrew from the market. It was actually quite a good device. So there are lateral TDRs, and Nuvasive and I think Globus still have a lateral TDR, which I've used. But the problem with that TDR device is that the core is very small and it's a mechanical device. So it tended to fish mouth because the core was so small for a lateral footprint that it didn't work very well. So I did a couple of those, but there is a problem with a mechanical device. So TDR selection is another thing. So it's a minefield. There are very bad TDRs on the market. Something like the M6 has a lot of problems. I heard that B Braun has withdrawn from the US market now. They've withdrawn the Active L has withdrawn from the US market. So in the US, you can only get a Pro Disc now. But there are problems with TDR. It's still a big learning curve, and the implants themselves are very variable. So we've used some horrible implants in the past, and there are descriptions of those. So it's all to do with knowing the quirks of the implant you're using. But the main thing is the osteopenia. It's a definite concern with any fusion or any TDR surgery.
And can you give us approximate risk of complication of inferior vena cava bleeding?
I have. So just last week, I had a patient where I retracted on not inferior vena cava, but common iliac. So common iliac vein, retracted it, and it was just micro perforations in the vein, and it bled. So I took off the retractor, it stopped bleeding, and I retracted again. It bled a little bit. So in the end, I just went below the bifurcation and pushed up the iliac vein up the other way, and we still got access to L45, but it's accessing from a slightly different approach. That worked for her, but that was an access to an L45. So normally going on left, but I had to go for right, actually from an L5S1 approach to get up to the L45 disc space. So it's just about mobilizing the vessels. So you have to be vascular trained, or you know how to repair the blood vessels if you have complications, or you have to have a vascular access surgeon.
Sure, thank you.
Do we have any other questions from audience members or faculty? So I've got some as well. So regarding this is to all the faculty, regarding the learning curve for posterior endoscopic and tubular, do we all agree that tubular is easier? So if because we're aiming at a very wide audience, so we all start with open surgery, and basically you have to know how to do the open surgery. So open surgery, and then would you agree that the next step would be tubular, or do you think that we can go straight from open to endoscopic? I put that to everyone who's presented endoscopic surgery now.
Yeah, maybe
could you skip the tubular and just go straight to endoscopic from open?
I may just cut in for a minute. May I just cut in for a minute?
Yes.
Yeah, sure.
It's very simple here. Endoscopy is an evolving field. After a few thousand UB procedures, I'm still learning. So we have not yet reached the level.
You are frozen.
Malcolm, you're frozen. Okay, well, he's frozen, so I'll just answer some of these questions. So we've got a chat group. So so one of the questions, are you doing disc replacement through lateral like Olaf? No, we're doing it through anterior. And another one is, see if what else have we got. How long do you expect the TDR will live before fusing, or where of the polyethylene materials. Okay, so the TDR I'm using, they've tested it to 40 million cycles. So if you do the maths on that, 40 million, and say you're 50 years old and you have the TDR put in, you've got and you live to 90, you've got 1 million a year to play with. 1 million a year, you divide by 365 days, means that in one day you can touch your toes 2,700 times. And during your waking hours, it would mean that you touch your toes continuously for all the time you're awake. For every 20 seconds, you're touching your toes once. The test up to 40 million was not a failure test. So the implant survived 40 million cycles and it was still working at 40 million cycles. So I usually answer my patients, as far as we're aware, the TDR will outlive you. The technology now is that the TDR we're using, because it's a viscoelastic device, it does not have any moving parts. The only thing that's being deformed are molecular bonds. There's no friction on it. So there's no wear particle, in other words, because all that's being deformed are molecular bonds. So it's two titanium end plates deforming a polyethylene silicon core. So that's the longevity of the implant. So any more questions from the audience?
Yeah, I have more question. I want to ask you if we compare the TTR of the cervical to lumbar, because the concepts are the same. Even lumbar has more loads.
Yes.
Compared to cervical spine. In 2000s, when the TDR for cervical spine came, it was very popular, then it fell out of favor, and now it emerged with very narrow indication. What about the data for TDR and lumbar spine? How far they are in the market, and is there any data to support long-term outcome?
Yeah, I have patients going back 20 years, and I've not had to revise any TDR, even my 20-year-old lumbar patients, and that was using a Charité and ProDisc. But we're getting better because those implants are mechanical. So there still is concerns with there are reports of failure with those types of implant because they're a mechanical device like a hip and knee replacement. So we don't know the longevity, maybe 20, 30 years, but 20, 30 years, it's still better than fusing the spine. Those patients are still doing well. None of them have adjacent, they're playing football. They're not, they work, the implants work. So we're not condemning the patient by fusing.
Yeah, biomechanical stability over the time. So my hospital, so I have a patient visiting me over more than 20 years. My senior professor performed the cervical lumbar TDL in many cases. So not every single, but majority of the patients still visit me. Their range of motion of the lumbar and cervical TDL more than 25 still works well. Some cases range of motion is very limited, but it's not fused yet. Still works. It's very informative, amazing the outcomes. Yeah.
So why prove the adoption of TDR and lumbar spine is not high compared this good outcome?
The surgical approach, you need another access surgeon. I think that's the main resistance in the US, which is the main market. That's number one, is you need an access surgeon. Number two is reimbursement. So even in Hong Kong, some insurance company will only get 2/3 of the reimbursement if compared ACDF versus an ADR in the cervical spine. An insurance company here will only pay me 2/3 for the TDR. And in the US, it's even worse. It's a half, apparently. So there's cost issues. And then there are also issues with some of the implants. So say the M6 implant, M6C, which is FDA approved. Matthew Scott Young in Australia has a 1 in 3 revision rate of that implant. It's a horrible device. And there are other devices that I won't mention here that have problems related to it. So it's the prosthesis itself. So this is very interesting science, how we can design something. But we know that fusions fail. We get cantilever failure, fusion constructs. We have problems related to non-union. So we try and fuse the spine. It really doesn't want to fuse. It's trying to move, and we just need an implant that's strong enough to sort of cohabitate with the spine and allow it to move properly without coming loose. And it's the implant core failure, and sometimes it's a risk of subsidence, and it's the failure of the bone implant interface, which is the osteolysis. Those are the things we're mainly concerned about. And in the cervical spine, HO, but we don't see that much in lumbar.
Perfect. I have a question if there is time and there's no other questions, because I want to encourage discussion. I have a question for Prof. Luke. Prof. Luke, in case of foraminotomy in patient with degenerative scoliosis, maybe spondylolisthesis, and you selected this approach as a transforaminal foraminotomy, how do you judge the durability of surgery? Is there any factors?
Yeah, there are a lot of the factors, obviously, but it is still challenging for me to make a decision in case of the foraminal decompression alone in patient having the sort of scoliosis, sort of the spondy, right? Because at the day of the surgery, I can decompress the foramen well, because it's totally related with the surgical procedures. You can resect the SAP, you can take out the foramen ligament. If you want to make sure you can do more decompression, including the IAP and the partial pedicle as well. The problem is not related with the surgical procedure itself, but truly related with the patient factors. In case of the patient having the ongoing stage of the slippage more, cups angle more, we cannot stop it at all, right? That is why I always explain the patient reoperation risk is a little bit higher than the usual cases. Sometimes it's going to be more than 20%, but in case of the old age population, more than 78 and more than 80 years, their daily activities are already limited, right? They don't enjoy the climbing mountain. They don't enjoy the swimming. They don't enjoy running, right? Their lifestyle is limited. They just want to enjoy the nice dinner with the family, just enjoy the strolling with the dogs, right?
Yeah.
So yeah, that's why it is possible in case of the old age population. Just take it out the small, just take to make the room for elevate the pain, right? But we cannot make sure the 5 years outcome, 10 years outcome is kind of the sort of the not so temporary, but it's not the permanent procedures. So there's bargain. So the discussion, this issue with the patient family is always crucial, right?
Sure. Prof, do you use currently endoscopic navigation?
Yeah, I love to use the navigation in case I'm gonna make sure my tip of drill reach out to the medial border of pedicle, right? Did I enoughly decompress foramen something, especially the raw cervical, thoracic, lumbosacral junction? Is if once we make the small incision, you cannot find where I am working on, right? So that's why the navigation works well. In case, not every single cases, but in case of so typical, the unique, the location, right?
Yes. So, Prof, if you use end of navigation, do you feel it's better in terms of decreased radiation exposure to you and to the team, or it's better that in terms of clinical outcome?
For surgeons, for nurses, for the surgical teams, right?
And for the clinical outcome, do you feel that it make a change?
No, I don't think so. The reason I like to bring the navigation is not for improving clinical outcome, but make the surgery the surgeons comfortable over the time in the OR, or increase the healthcare issue, especially your nurses are mostly ladies. Yeah,
Yes,
right.
sure. Is there any other questions from the group? Maybe I can answer Dr. Raymond's question.
Yes.
Because you ask about training and tubular decompression. I have very special training because I was trained in complex spine surgery. Then I did minimal invasive spine surgery fellowship in France. My first training was in Canada. Then I joined Prof. Luke for 1 year to learn endoscopic spine surgery. I did not have time to practice each one of these because my fellowship were consecutive to each other. So when I went back to Saudi Arabia, I was before going there as a neurosurgeon doing a lot of open decompression. I easily adopted the tubular decompression in my first few months. Then I introduced interlaminar endoscopic decompression, which is not very different from tubular decompression. Then I introduced transforaminal discectomy. Then I introduced transforaminal lateral recess decompression. Then I introduced the ULBD, unilateral laminectomy bilateral decompression, using the monoportal, then using the biportal technique. I mean, each one can expand his the techniques and what he likes and what he want to do. But in general, open, then MIS, then interlaminar, then transforaminal. This is in my opinion.
Okay, thank you. And so one of the problems when we're doing spinal decompression at L34, L23, if we go that high up, is actually trying to preserve the pars. Okay, so I cannot do a tubular at 2-3 and above usually because the spinal canal is so narrow. So what I do is I go midline with the tube. I go into spinous and try and decompress. So would that be easier with the endoscope? Because I've seen endoscopic cases where they've actually managed to create a pars defect because it's similar to
that's
going,
good. Yeah, that's the
so
good point in case
what
of
do
the
you guys
upper
do at
level.
L23 and above? Because I mean I do the transforaminal, but interlaminar is difficult at 2-3 and above. So sometimes I'll just take out the spinous process. It's not that unstable there, and we'll just decompress the canal that way. Or I've done it tubular, but we go into spinous process rather than going to the side because you just can't get in without destroying too much of the joint.
I have the same page with you that in case of the central canal decompression at the 2-3 and 1-2 level, interspinous approach is has much more advantage to saving the body joint. With the endoscope has the eye optics angle 20 and 25. So the width diameter is the size is good enough to get in this interspinous window. So that is why it is possible compared to the microtubular surgery. Full endoscope has a strong advantage, the proper manner of decompression, especially upper level, right?
Yeah.
Yeah, that's why it was possible. It was possible for me to the adequate decompression, even if the patient have the the facet tropism, right, without the damaging the facet injury. But the same surgery, if I put the tube, I probably take out the IAP, probably injure the facet joint.
Yeah.
right? That is a different, right? But level 4, 5 to 5 Essam, there's no obvious differences, right?
Yes.
But
Yes.
upper level, we can make it different
Yeah. Difficult.
with the endoscope, right?
Even when we're doing the tubular, or I guess even endoscopic, what we usually find is that the upper lumbar levels, unless you have the patient in a lot of flexion, the interspinous space doesn't actually exist. You've got two spinous processes that are kissing. So you have to take down some bone to get in there. But I prefer the midline over taking out the facet joint there, because you could be creating an instability or further problems by going
That's a
paramedial.
clever way. That's a clever way. Yeah.
I have a question for Luke. I have seen a lot of patients with adjacent segment disease who had previously fusion from 3 to 5, and they have spine stenosis and adjacent segment disease at 3, 4. And I did one of these by endoscope, and it is very time consuming because the lamina on the upper level is very thick compared to lamina and L5 and this one. So is there anything, I know the angulation of the optics makes the bone cutting much less in endoscopy compared to tubular, but if the patient is a male and the facet is more coronally oriented, do you still go by endoscope, or maybe you use a smaller tube like 16?
So that's one of the challenging questions. There's no obvious solid evidence for about the endoscopic decompression in case of junctional problem. But I can say any kind of decompression alone with the endoscope or microtube, in case of the AST, that cannot be a panacea, because that AST has the result of sort of the aging process, sort of the the problem is still ongoing. Even though we can make the beautiful decompression, maximal preservation of the normal tissue, we cannot stop the ongoing process. The best way is minimize, but it's not even though the patient didn't have the operation scar there, it's interesting when we advance bring the scope in, we always see the adhesion scar, right? Because the previous low level sort of the surgery is much more tough than the others. So the adoption of the endoscope solution for the AST should be cautious, right? I love to foraminal decompression in case of the single pinpoint the radiculopathy coming from the AST. I love to use the endoscope. But interlaminar decompression, there's no obvious difference between the microscope versus endoscope. This kind of just the experimental surgery. So saving the facet joints, so minimal differences, right? So indication is always crucial. If the patient have the disc prolapse with the junctional at the level of junctional problem, any kind of decompression cannot be successful. Eventually, patient have to get a fusion extension or TDR if it is indicated. I'm gonna ask this issue, Raymond, but
yeah, we do TDRs for adjacent segment disease.
yeah.
I
think that might be safer than the endoscopic decompression. So time is already.
Yeah, I think we're over. So thank you, everyone. I hope it's been a great talk for everyone. And the next one should be scheduled in 2 months. And I don't think Arvind and I have anything lined up. So if anyone wants to propose a topic, we'll try and find some speakers who do it and present something similar like today. So a topic and how, different management options. Or if we so just send us a message saying what you would like to discuss, and we'll try and organize a webinar for everyone.
Okay.
to next one is 2 months' time.
Thank you.
Thank you, everybody.
Thank you, everybody. Have a good